My name is Jara, and I'm going to talk about Pheochromocytoma and Paraganglioma. So, what is Pheochromocytoma and Paraganglioma? They are known together as PPGLs. Pheochromocytoma is a rare tumor of adrenal gland tissue. It results in the release of too much epinephrine and norepinephrine, hormones that control heart rate, metabolism, and blood pressure.
A pheochromocytoma is a tumor of the adrenal gland that essentially is of the cells that make adrenaline. So if you think of the things that adrenaline does for your body, causes racing heart rate, causes flushing or sweating, these are all symptoms of a pheochromocytoma. So a pheochromocytoma can cause flushing, high blood pressure, and fast heart rate. A lot of times these symptoms are intermittent. They come and go. A pheochromocytoma is diagnosed through a series of blood tests. We usually check your levels of epinephrine in your blood and in your urine. And usually a CT scan is needed to diagnose which adrenal gland has the pheochromocytoma in it. Pheochromocytomas are then treated with surgery, but it's very important to know that someone has a pheochromocytoma before surgery because we need to give you special medications to control your blood pressure before surgery with a pheochromocytoma.
Paraganglioma is a rare type of tumor that arises from the part of the body's nervous system that control blood pressure. Paragangliomas can occur in the head, neck, chest, or abdomen. Pheochromocytoma and paraganglioma are rare tumors that come from the same type of tissue.
Paraganglioma, as the name implies, is a tumor of paraganglia. Well, paraganglia are cells that are located in various parts of the body. These cells are located in the middle ear, up against the inner ear, and also located in an area called the jugular bulb. And if I were to look back at the back part of this model, I would see that the sigmoid sinus, this is a major vein that drains blood from the brain and empties into a large channel called the jugular bulb. This also has the same sort of cells that we're talking about in the middle ear, the cells called paraganglia. Well, the purpose of these cells is really to detect oxygen and carbon dioxide levels in the bloodstream and get that information back to the brain. Well, for unknown reasons, mutations can occur within these paraganglia cells and causing tumor formation. Most and almost all paraganglia are usually benign. There is a malignant variety of paraganglioma, and it's just referred to as malignant paraganglioma that can metastasize, that can spread from the ear to lymph nodes regionally and throughout the body. So it's important to make the diagnosis. Typically, the diagnosis is made by an astute physician who encounters a patient who has pulsating tinnitus and hearing loss, and a conductive hearing loss. And when they look inside the ear canal under a microscope, they can visualize the tympanic membrane, and they can actually see the paraganglioma behind the eardrum. This is what we call a glomus tympanicum. These paragangliomas also have another name, and that is glomus tumors. So these glomus tumors that arise in the middle ear are called glomus tympanicum tumors. Those that arise in the jugular bulb are called glomus jugulare tumors. These are just a difference in names, if you will, but really the same kind of tumor. A glomus tympanicum tumor, very easily treated with removal and excision. A glomus jugulare tumor is much more problematic, and treatment is really tailored according to the symptoms that the patients have.
Now I'm going to talk about applications in medicine. Some of the symptoms are the following: headache, heavy sweating for no known reason, a strong, fast, irregular heartbeat, being shaky, being extremely pale. Signs and symptoms of pheochromocytoma and paraganglioma may occur at any time or be brought on by several events: physical activity, childbirth, anesthesia, among others, etc.
Hello, pheochromocytoma. Pheo means dark, chromo means colored, cyt means cell, and oma means tumor. So this is a dark colored cell tumor. Stomas in the adrenal medulla. 90% of the cases are found here. And which are the adrenals? Adrenals are the organs sitting on top of the kidneys. And we can divide the adrenal gland into cortex and medulla. And we see that in the medulla, we have epinephrine and norepinephrine, which is being produced. And 90% of pheochromocytomas are in this medulla region. So this is the picture of the tumor. Here we can see the tumor in the adrenal gland. And as we said, it secretes catecholamines, epinephrine, norepinephrine, dopamine. The other name of epinephrine is adrenaline. The other name of norepinephrine is noradrenaline. And we have to remember something called 10% rule. It means that 10% can be extraadrenal. It means that it is not found in the adrenal gland. It is found some other place extra-adrenally. For example, the paraganglioma. And the typical site is the sympathetic ganglia, and especially the organ of Zuckerkandel at the aortic bifurcation. And here you can see the picture of it. We have the sympathetic trunk, and at the aortic bifurcation down there, we have the organs of Zuckerkandel. 10% can be malignant, which means that it is not benign. It's the opposite of benign. So benign is when we have an enclosed tumor. It is not so dangerous as the malignant type. The malignant have an irregular border, as you can see, and we have neovascularization, and it is invasive, so it can spread to the whole body. 10% are familial, meaning that it is inherited in the family. 10% can be multiple. Here you see the picture of a liver with multiple metastases, so multiple tumors. 10% can be bilateral, standing for that we have both adrenal glands affected. 10% can calcify. Here you see the whitish, hard calcific deposition in the tumor. 10% can be found in children. And then we have the symptoms of 6Ps. So the patient comes in and will typically be presented with symptoms that start with P. Panic attack, for example. Pressure, for example, episodic hypertension. Pain, for example, headache. Perspiration, like sweating. Palpitation, like tachycardia, which means an increased rate of frequency of the heart. So you see the normal picture on the upper one, and the lower one is an increased rate. So this is a ventricular tachycardia, for example. Pallor, which stands for pale skin. So it's a whitish pale skin. And the diagnosis then can be done with the symptoms and with blood tests. And what we will see in the blood, hyperglycemia. So it is an increased amount of sugar in the blood. Hyperlipidemia is an increased amount of lipids, meaning fat, meaning cholesterol. We can have hypokalemia, which is a decreased amount of kal, standing for potassium. So we have a decreased amount of potassium. And the banana picture just shows that we have a high amount of potassium in bananas, and in pheochromocytoma we have a low amount of potassium, and therefore I have just drawn this sad banana, standing for that it is decreased. Urine. In the urine, we can typically see epinephrine, like adrenaline, metanephrine, which is very important in this disease, normetanephrine, vanillyl-mandylic acid, and homo-vanillic acid. We can localize the tumors by imaging, for example, CT and MRI scans. And then we do the treatment. We start with medications first, and we typically start with alpha blockers, like phenoxybenzamine. Then we do beta blockers, propranolol. And then it is important to remember that you always give alpha before you give beta blockers. Otherwise, you can get a hypertensive crisis. And alpha blockers are typically used before 10 to 14 days before the surgery. Beta blockers 3 to 5 days before the surgery. And then we have the surgery. And the surgery is a typical laparoscopic adrenalectomy. And this means that we have a laparoscopic method that you puncture with different holes in the abdomen with some cameras, and in this way it is not so invasive as an open surgery where you cut up the whole organ, the whole abdomen, and therefore the healing rate is much quicker in this case.
So the question itself mentions that it is a T2 weighted MRI in a female with refractory hypertension. So we have to diagnose the condition. So here is a lesion on the left side, which is above the left kidney. That is the left kidney. This is the right kidney. The lesion is suprarenal in location, that is arising from the suprarenal or adrenal gland, and it is a T2 weighted MRI. The lesion is bright, that is white on T2 like a light bulb, which we have seen previously, that is pheochromocytoma. So the correct answer is pheochromocytoma. Cushing's disease would cause hyperplasia of bilateral adrenal glands, that is both adrenal glands would be bulky, and pheochromocytoma is associated with MEN 2 syndrome and not with MEN type 1. So the correct answer is option C, that is pheochromocytoma, which has a light bulb appearance on T2 weighted MRI.
Now I'm going to talk about data in Ecuador. There are around 28,000 cases of cancer reported in Ecuador each year. In Quito, there were reported 28 cases of paraganglioma in 2016. In Guayaquil, a case of pheochromocytoma was presented and successfully treated last year. Here we can see a picture where there's more details in Spanish.
Pheochromocytomas and paragangliomas are a very rare subtype of neuroendocrine tumors. Difference to most of the others in that they unfortunately carry a very poor prognosis when they have a proper malignant phenotype. So 80% of these patients will be cured just by surgery, but there is 20 to 30% of them that would either have a recurrence after surgery or would present with metastatic disease. And unlike most other neuroendocrine tumors, Pheos and paragangliomas do not really respond very well to conventional therapies, including chemotherapy. There has never been a trial showing that these treatments will prolong survival of patients or improve their quality of life. So there is an acute need for novel therapies. In terms of our own study, we wanted to look at the interplay between hypoxia and the regulation of PD ligands, which are two molecular mechanisms on which malignancies tend to rely on to progress further, knowing that actually PDL1 and PDL2 expression is an actionable driver of the immune response for which new therapies are available. So what we found is that, quite strikingly, 15 to 20% of the patients who present with pheochromocytomas and paragangliomas do display an upregulation of either PDL1 or PDL2, to suggest that these two targets are somehow involved in the immune tolerogenic environment in these tumors.
In conclusion, these are uncommon and complex pathologies. The surgical resolution is mandatory in benign cases with multidisciplinary surgical preparation to decrease the maximum morbidity and mortality, and with long-term follow-up in all cases. Thank you.